My name is Colleen Berry, and I'm a professor in the Department of Health Policy and Management here at the Johns Hopkins School of Public Health. And I want to thank you all for joining us to engage in what will be an ongoing conversation about the future of public health in the context of the election of Donald Trump and the start of the 115th Congress. We've had and will continue to have numerous forums and discussions on the implications of the election on this campus. In the Department of Health Policy and Management, in partnership with our other departments and our Dean's Office, we are interested in beginning immediately to focus specifically on health and healthcare policy in the context of the new administration. Initiating this discussion is extremely important, I think in part because so little of the presidential campaign was based on substantive discussions of issues of policy. Yet, we know that all administrations have to adopt policy, and that these policies can have wide-ranging consequences for health. Over the last day or two, the President-elect's transition team has begun to announce key appointments, with Congressman Tom Price named as Secretary of the Department of Health and Human Services, and Seema Verma, an alum of our MPH program, tapped to lead CMS. We are now beginning to get clues about the contours of what may lay ahead with regard to health policy. Here on campus, we'll be aiming to convene more in-depth discussions about some of the specific issues that we're going to touch on in this forum today, including the ACA, Medicare, Medicaid, but other topics such as gun policy and environmental policy that will be impacted by the election and that are critical to the work being conducted at our school. In this context, I would encourage us all to think about this discussion in this forum today as the beginning of what will be a much longer conversation. Now, I'm honored to introduce our panelists. First, I'm pleased to welcome Congressman Henry Waxman for what will be our final symposium with him as our Centennial Health Policy Scholar. As all of you know, the Congressman represented California's 33rd Congressional District for 4 decades and played a critical role in advancing policy in a wide range of areas critical to protecting the public's health, including tobacco policy, pharmaceutical policy, expanding insurance, and many other issues. And he played an instrumental role in policy debates over the preservation of key health programs, including Medicare and Medicaid, in the period after the election of Ronald Reagan in 1980. Over the past year and a half, we have been honored to have the Congressman as a vital member of our community here as a Centennial Scholar. I'm also very pleased to welcome Bill Kaur to our campus. Bill served as Deputy Secretary for the Department of Health and Human Services under President Obama's administration from 2009 to 2015. Prior to this, Bill has had a long and distinguished career in public service, including serving as Chief of Staff for Secretary Donna Shalala at Health and Human Services during President Bill Clinton's administration, and as Chief Counsel to former Senate Majority Leader Tom Daschle. Finally, it's my great pleasure to welcome Karen Davis. Karen has a long and distinguished and rich history in our department. Karen served for over a decade as our chair of the Department of Health Policy and Management. After that, she served for 13 years as the president of the Commonwealth Fund. Karen has served as Deputy Assistant Secretary for Health Policy in the Department of Health and Human Services from 1977 to 1980, and was the first woman to head a U.S. Public Health Service agency. We were fortunate to recruit Karen back to Hopkins a couple years ago to lead our Lipid Center for Integrated Healthcare. In terms of process, we passed out cards at the beginning of the session. Does everyone have their cards? as you entered Sheldon Hall, you should have received a card. If you have specific questions for our panelists, this is how we're going to sort of structure the session. Please write those questions on the cards and pass them this way toward the aisle. Susan Morrow, who's been instrumental, thank you, Susan, in organizing this session, is going to collect those cards. And after an initial set of questions from me as moderator, we will do our best to incorporate your questions into our panel discussion, and as many of those questions as we can manage within our limited time period. So now let me first turn then to a first question for our panelists. Congressman Waxman, for some of our students who have literally grown up under 8 years of an Obama administration, the election outcome, I think it's fair to say, for many of them, feels like a total sea change. After 4 decades in Congress, you have perhaps a longer view. And we want to ask you what insights you can share just to begin to help us understand what this change means and holds for health policy in this country.
Well, thank you for that kind introduction, and I want to say, because I've been, the last time I'll be with you as a Centennial Scholar, how much I've enjoyed the opportunity to be in forums like this, and talk about some of the health issues that we all care about, from Medicare, HIV/AIDS, tobacco. We even had a session on climate change. But we are in uncharted territory with this new administration as it comes to figuring out what will happen on public health and health policy overall, because the campaign didn't talk about those issues particularly. It talked about making the country great, talked about the personalities and the deficiencies in the other candidate as each one attacked the other. And we're now starting to see what President Trump is expecting from his administration by some of the statements he's made, but by the people he's appointing to carry out those policies. I think we have to remember that we've had times in the past where we didn't know where things were going to go, and we always expected the worst. And I guess the point I would make is you have to push back. You have to argue the logic and the facts and the consequences of certain policy decisions, whether you think it's going to happen or not. The Trump administration and the Republicans, who now control the Congress, have the problem that all congressmen have had, and that's that in the Senate, a vote doesn't come by 51. It's usually by 60 till they get to the vote itself in order to stop the debate. But there is a process called the budget process, and that only requires a simple majority to adopt the budget and then a simple majority to implement the budget. When it comes to health care policy, the talk is that what they will attempt to do very early in January and February is to adopt a budget for this fiscal year, 2017, which goes till September 30th of next year. And in adopting that budget, the budget spells out how much can be appropriated, but the budget also allows for what's called a reconciliation legislation that can, within certain parameters, implement policy. So, for example, if they cannot repeal the Affordable Care Act, but they can repeal all the funding for the Affordable Care Act by way of subsidies for those who are in the law and qualify for those subsidies. It could stop the payment in Medicaid for the expansion of Medicaid, which was part of the Affordable Care Act. There are other things they can do that affect the numbers. They can't say that they can't adopt by a majority vote the policies that would say it's okay for insurance companies to discriminate based on pre-existing conditions, or that children could be on their parents' policies to age 26. That's the law, but they couldn't change it in this process. They'd have to do that through a process that would require 60 votes. So it offers a potential of a very fast-moving train, and we've got to, those of us who will disagree with what they're trying to do, try to stop it so that people can pay attention to what's happening and try to discourage some of the extremes of the proposals that we've seen in recent years. One thing for sure to keep in mind as we make our case in opposition or in support of some of the policies that will be put forward is that we've got to make our case on the facts. We've got to make our case so that people understand it. We can't talk in just generalities, but we've got to show what the impact will be in human lives. And I think there will be a huge impact if you take 20 million people that are covered, or 25 million covered under the Affordable Care Act in the individual policies, and no longer allow them to be able to continue to benefit from the Affordable Care Act. I think that if they simply say that we're going to make these cuts but 2 years from now, while it may say that they may seem like we have a period of time before we can get to the replacement, which they've never spelled out for us, for the Affordable Care Act, but the consequence of saying that the money will stop in 2 years will be a signal to the insurance companies not to be in that market, because they won't be able to rely on the idea of the Affordable Care Act continuing. So there will be an impact, a real impact, pretty fast. People will have their policies for 2017, but as they look at 2018, it's going to be questionable what will be available. They may bite off everything, because we know that they want to take Medicare and put it into a price support voucher system. They want to take Medicaid, not just expansion of Medicaid, but the program of Medicaid, and make it into a block grant. These are things that Republicans have been talking about doing for a very, very long time, and they've tried in the past and failed, even when they had control, with the same party control. But it's not going to be easy, because there are going to be a lot of pressures for Republicans and Democrats to think through, especially if we do our job, what the impact will be. So I don't want to say we've been there before, but I was there in 1980 when Ronald Reagan was elected president, and he had a Republican Senate and a House that was pretty much under his control as well. They adopted a pretty extreme budget, but when they came to trying to make the final decisions, we were able to pull them back. Even when they proposed putting a cap on Medicaid, we were able to get them to look for an alternative that didn't permanently hurt the system. There are a lot of stakeholders that are going to be questioning the policies. So for those of us who care about health, public health, look at the facts, look at the policies, speak up about what the effect will be, and then be part of the process as best we can to try to minimize what we think may be damaging ideas for the future. But keep fighting, keep pressing back, and make sure that our voices are heard, because our voices are speaking up for so many people that won't be able to have a voice in the process when the abstract notions of simply holding down the spending in Medicare and Medicaid entitlements down the road for the purpose of providing more tax cuts for the upper income will be on the minds of people without realizing, well, wait a minute. They've heard that there are consequences, and we've got to keep reminding them of those consequences.
Thank you. Bill, I want to bring you into this discussion about repeal and replace in particular, and the policy and political issues around repeal and replace. As the congressman signaled, we've heard from the president some interest in potentially retaining some specific components related to protections for individuals with pre-existing conditions, and the dependent care provision, which would allow young people to stay on their insurance policies till 26. Yet, as the congressman pointed out, these aren't provisions that would be part of a reconciliation process involving just fiscal and budgetary items, so would be subject to the rules of cloture. And so my question for you is, what do you think will happen here? And how can we make sense of these limited signals that we're seeing coming out of the administration about the potential direction in terms of what we know about insurance markets?
Well, that's the question, of course, everybody's sorting through. Certainly in Washington, and I know you all are too. Henry touched on a number of the things that I think are about to happen. And let me try to just reframe it just a little bit so you have a sense of the complexity of what is about to happen and when certain decisions are going to get made. The signals, if you call them that, from President-elect Trump, as we all know, have been varied, not only in health but in many issues. He talked throughout the campaign constantly about repealing the Affordable Care Act. He didn't talk about what do you do with the 20 million people that have insurance now. He didn't talk about the public support for the Affordable Care Act and the many people who depend upon it. But then in his first meeting with President Obama, he came out saying, well, some ideas in the ACA sound pretty good. And I think this has sort of been the pattern throughout the campaign, and now I think during the transition, where it's not clear where President-elect Trump is on many issues. So there are other signals we can certainly look at, and there are plenty that we're now beginning to get. First of all, President-elect Trump didn't really talk about Medicare much. But then he selects Tom Price, the budget chair in the House of Representatives, orthopedic surgeon, who has a long record. He's talking constantly about, Congressman Price is, about the same sort of agenda that Speaker Ryan talks about and that is published. And so if you look at the two people that President-elect Trump is working closely with, you can see an entire agenda that President-elect Trump has not referenced. But it's a totally different agenda. And I know you all have probably had a chance to look maybe even at Congressman Price's legislation that he introduced. But he and, if you will remember, President-elect Trump talked during the campaign about health savings accounts, tax credits, insurance across state lines, state high-risk pools, block granting Medicaid. But it's very hard. I think reading President-elect Trump's signals are not the ones we've got to be looking at. We know, as Henry was pointing out, we know what Republicans are talking about doing in the Congress. And it is moving very rapidly towards the opportunity to effectively repeal the Affordable Care Act. As Henry mentioned, there's going to be one budget reconciliation bill for FY 2017. They can come back in the spring and summer and do a second reconciliation bill for FY 2018, because remember, that starts October 1, 2017. And so there are going to be two reconciliation bills that only require 51 to pass. And there is talk of the president trying to put tax cuts, the debt ceiling, repeal and maybe some aspects of that set us up for replacing the Affordable Care Act. Will there be Medicare changes that will be in there? We would expect a block grant for Medicaid or maybe some per capita cap, a change in the way Medicaid is structured. But if you look at where Congressman Ryan is, what he's talking about doing, and when you look at what Congressman Price, soon to be the HHS secretary, what they're talking about doing, I think that's where we're headed. And the question in all this is probably the biggest question is, will President-elect Trump go with that, or will, for some reason, he take a different position? He has surprised us in a number of ways. We're getting signals on Medicare because of what Congressman Ryan and Congressman Price are talking about. And we don't have a position. I don't think we have a clear idea of where President-elect Trump will be on Medicare. This is something that, as Henry said, that for a long time now, Republicans have been pushing block granting Medicaid, turning Medicare into a voucher, in essence, a voucher program. They are, Congressman Price is very determined to build up the private health insurance industry by giving everybody a little bit of money to go buy their own health insurance. There are signals from the insurance companies. Many of them have pulled out of the ACA, as you all know. They're in the process of trying to find the right rates to reflect the population that they've got. But if I were running an insurance company, I don't think I'd be looking much past 2017. They will have to make their decisions about 2018 by next summer, I believe. So there are lots of signals that are going to continue coming, but the ones that you really need to watch for, the ones that really make the difference, is when these decisions are going to get made. And as Henry pointed out, there'll be a reconciliation bill that will probably have effectively repeal the ACA. We expect another one in which these other aspects could be there. Keep in mind that there's also a major Republican position that we should pay for tax cuts. We should reduce the federal deficit. We shouldn't be expanding the federal deficit. Well, President-elect Trump blows a hole in the deficit with his infrastructure proposals, with his tax cuts, and what's going to happen is when you turn to Medicaid block granting, or you turn to Medicare, and you turn to non-defense discretionary spending, those are the places where you offset increases in defense and you offset tax cuts. And they couldn't possibly offset all of that President-elect Trump has talked about. But we are headed towards even greater pressure than just the normal. The idea of a block granting Medicaid has always been giving flexibility to the states and reducing federal spending. And they go hand in hand. We're not going to do the first from Republican proposals without also reducing spending. The larger the deficit gets because of tax cuts, the more they're going to have to find in Medicaid and Medicare and non-defense discretionary spending. So in a lot of ways, virtually everything we work on in health is sort of on the table. And we can make cuts in spending that will fundamentally change our ability to carry out some of the work that we're now doing. So I think the important thing for you all to watch for is the process we're going to be following, because I think, in essence, as unclear as the signals have been from President-elect Trump, I personally think the signals are very clear about where the Congress wants to go. And the only question in my mind is, does he throw them for a loop by saying, no, I don't want any insurance company to be able to deny someone coverage because of a pre-existing condition. And that doesn't work with a lot of the stuff that Congressman Price has put forward. So lots of signals still to come, but I think we've got, from the history starting with Ronald Reagan forward, we have a sense of the policies that we're going to be facing. And I would just like to say one other thing about Henry. I've worked for Henry for 10 years back in the 1980s, and he's a dear friend now, and we work together now. And it is his attitude, it's the attitude of people like Karen Davis and all of you that are going to carry us to a place. We can argue over healthcare policy, and that's what we ought to be arguing about. There was a time when I first joined Henry in the 1980s where we used to have subcommittee meetings where we actually debated health policy. That doesn't happen anymore. And the two parties, unfortunately, have gotten so separated. So now is the time where, if you care about these issues, you've got to make your voice heard, and you've got to keep doing the work that you're doing. And I'm confident that it may take us a while, but that we will also get beyond this, because I think the policies that are in place now really best serve the American people. And hopefully they will see that over the course of the next couple of years.
Karen, Bill made reference to Medicare and premium support proposals. Throughout your career and in your current role with the Lipid Center, you have been dedicated to the use of policy and economics to advance the well-being of elderly individuals. Can you explain to our community in relatively straightforward terms what premium support is all about and what might be in store for the Medicare program under the new administration and the new Congress?
Well, delighted to have that chance. But I would like to take the opportunity to just say what I think all of us can do to make a difference, and then reinforce some of the points that Congressman Waxman and Bill Korf made, and then turn specifically to Medicare. I've seen a reference to we're all going through a process of denial, anger, negotiation, acceptance, and I don't think that's the right model. This is not a terminal illness. We need to prevent this disease. We need to mitigate the harm. We need to rehabilitate. We need to cure. So we need to use our public health skills to figure out how to get organized, how we can make a difference, and how we can act. By denial, I think I've had people come to me and say, you don't think he will really try to repeal the Affordable Care Act, or this will take time and it'll stay in effect for a while. And once they really try to figure out how to replace it, they'll decide it's complicated and it won't really play out the way we think right now. But I think rather than denial, we need to do what Bill Korf has suggested. We need to assume almost a worst case in terms of timing, that this will be pushed forward through budget reconciliation. So whether that's the 2017 reconciliation that typically would go through March to May, or it's later in the summer and a reconciliation 2018, we need to assume that they're going to try to fast track changes and that they want to move before the opposition gets organized. In some ways, Lyndon Johnson learned that. President Obama tried to move fast and maybe should have moved just a little bit faster. But people understand that once the public understands, different stakeholders understand what's involved, that get organized and pushed back. So we need to just go on the assumption this is likely to move. So what do we as public health experts do when there's an epidemic, a breakout of a new virus? We gather information, we get informed, we apply our analytical and critical thinking skills, we gather and we analyze scientific evidence and data, and then we communicate that effectively, and we get mobilized and join with others who share a common concern and make a difference. So that's kind of the theme of what I think we should do. Get over denial, anger. It's fine to go through those stages if you want to, but let's focus on what we can do. So I think we need to, right now, not wait until there are legislative proposals on the table, but right now, we need to analyze specific legislative proposals. And I think there are three things to do. I'm an economist, follow the money. So that's the number one thing. Two, follow the people and identify who gets harmed, who gets helped. But to say follow the money, I'm just amazed that nobody focuses on the fact that the Affordable Care Act raised $1 trillion over 10 years to cover the uninsured through Medicaid expansions, subsidies for health insurance coverage through the state marketplaces. And that money was about half from changes to Medicare and about half from new revenues. The Medicare changes It's about $200 billion that came from trimming the private insurance Medicare Advantage payment updates. Many of us would have argued, and certainly analyses by congressional agencies found that they were overpaid, so it was beginning to ratchet that down. And the other part of the Medicare savings, the American Hospital Association showed a lot of leadership, and they said, if you're going to cover the uninsured, we'll have less bad debt, and we're willing to take less in the way of an inflation update, 1 percentage point a year, because we'll have less bad debt, because we assume we're covering the uninsured. So those were the Medicare savings. There were revenues. We don't say taxes. Sometimes we say Cadillac tax, but there were taxes on high-income households from income, from dividends, rent, capital gains. There were fees on the industry, medical device industry, insurance, pharmaceutical companies, tanning salons. I was always very interested in that. Not that I go, but why? Why did they pick tanning salons? I don't know why Speaker Boehner let that go through. Employer and individual mandate fees. So $1 trillion. What is going to happen to that $1 trillion? Are they going to repeal those taxes? Everyone who had to pay more money or give up money would like to have it back. So is that $1 trillion going to go away? Is it going to go to pay for tax cuts for the wealthy? Is it going to go for replace? Is $1 trillion of it going to provide health insurance in another way to people? So following the money, to me, is the first thing that's important to do. The second thing, follow the people. We've heard about from Congressman Waxman that 25 million people are uninsured, but who are they? Who are they by state? Is a governor going to know that all of a sudden 2 million people that they've covered are now they're going to get zero federal financial support for their coverage? So how does it vary by age, by gender, by income? And then third, identify who is harmed and who is helped. So the first thing you need to know about insurance is expenditures are very skewed. 10% of the people account for 2/3 of the spending. Who is going to be hit are the sick. And those people who are high users, that's where the money is, and people who are poor. So the poor and sick are going to be hurt. And the healthy and the wealthy are likely to do well. So we know that in a general way, but how specifically will these proposals, and it's not just by income, it's how much will a state lose in the way of federal money? Believe me, that is a powerful argument against change, that a state knows this many $1 billion that were coming into this state that was going to hospitals to hire people, and the state is now going to lose that money. That's important evidence. Or the industry, how's the insurance industry going to fare, or the pharmaceutical industry? So those are the kinds of analyses. So let me turn specifically to Medicare. I agree totally with Bill that we know because of the nominees exactly where this administration is heading. And the thing I would say, this is not just about repeal and replace the Affordable Care Act. This is making fundamental changes to the structure of Medicaid and Medicare. It's not just rolling back President Obama's legacy. It's rolling back 50 years of Lyndon Johnson's policies. So don't just focus on repeal and replace, focus on Medicare and Medicaid. And specifically, as Bill has pointed out, Secretary of HHS designee Congressman Tom Price, who chairs the House Budget Committee, has recommended changing the entitlement nature of Medicare and Medicaid, moving away from covering a defined set of people for a defined set of benefit. He has supported converting Medicaid into block grants to states. And a lot of that, when you get into the specific bills, if you're fixing the amount of money, when did you fix it? Is it pre-ACA, before they expanded Medicaid? Or is it today's dollar? So what are we starting as a base? And what strings are attached on using those block grants for Medicaid? There have been a lot of proposals to say, well, if you're able-bodied, you need to have a job, or you need personal responsibility. And what's the effect of a block grant? CBO has done estimates on most of these proposals, estimating that the block grant would lose 14 million health insurance coverage. On Medicare, Congressman Price has supported switching it to a defined benefit, from a defined benefit to a defined contribution. And so the government would give older and disabled Americans financial help to buy private insurance. So he says it's not a voucher because he doesn't give it to the people to give it to the insurance company. He gives it to the insurance company and tells them if they can do it cheap, that'll be enough. But if they can't do it cheap, they're going to have to get the rest of the premium out of the elderly and disabled. So I urge you all to go. You know, internet's wonderful. It's very easy to look up Congressman Price, HR 2300, Empowering Patients First Act, and you can see specifically the repeal and replace legislation that he has submitted in the Congress. Obviously, it repeals the Affordable Care Act. It replaces it with tax credits that range from $1,200 for a younger adult to $3,000 for an older adult. So it depends on age. It's not available to people who are covered under federal programs, but if you want to opt out of Medicare and take that tax credit, you can. Or if you want to opt out of Medicaid. So if you're healthy and a fixed amount of money can get you a good deal in the private insurance market, you can leave so you can unravel the Medicare program by getting the healthy to come out with a tax credit. He also has a refundable tax credit for health savings accounts. He has a cap on employer contributions to health insurance, so it's also an attack on employer coverage, $8,000 for an individual, $20,000 for a family. If an employer pays more than that on a health insurance, it's taxable income to the worker. He's got grants for states with high-risk pools. We all took some comfort after President-elect Trump met with President Obama that he would keep provisions for pre-existing conditions. When you read these bills, what they're talking about is dumping you into a state high-risk pool. So you've got one time to get covered. If you become unemployed and you can't afford your health insurance premium and you drop coverage, then what's left in the future for you is to go into a high-risk pool where your premiums are 5 times what they are for healthy people, where the deductible is $10,000. We have a lot of experience with these state high-risk pools. So that's what's available to you if you've got a pre-existing condition. You can be covered just with a huge premium and a huge out-of-pocket expenses. And then, as Bill said, grants for states with high-risk pools, association of health plans, portability of individual coverage sales across state lines. But the Medicare stuff is spelled out in Speaker Ryan's proposal, which is called A Better Way. It was called the Path to Prosperity. You know, it's had different names over time, but it's currently called A Better Way. So again, you can go on the internet, get the provisions. He presented it in May. It's missing a lot of the important critical details, but you get the structure. Convert Medicare to premium support beginning in 2024. So he said it's not going to affect anybody who's now on Medicare. They're grandfathered in, unless they want to take the voucher, the premium support, and buy private insurance. He'll adjust it for health status and income, give beneficiaries a choice of traditional Medicare or premium support for private coverage. He will merge the Part A hospital deductible and Part B physician deductible. Doesn't tell us how much. He'll put a ceiling on out-of-pocket costs. Doesn't say what that ceiling will be. Prohibits Medigap plans, private plans, from filling in the deductible and from filling in more than half of the difference between the deductible and the out-of-pocket ceilings. It raises the age of eligibility of Medicare from 65 to 67. It replaces all the low-income programs that Congressman Waxman got introduced over time, called the QINB, Qualified Medicare Low-Income Beneficiary, SLIMB, the Supplemental Low-Income Beneficiary Assistant, Qualified Individuals, QI. All of those would be collapsed into a single program with a single asset test, not telling us what the income level of eligibility or that asset test would be. He would give back to the Medicare Advantage plans the higher payment that they were getting pre-ACA, $150 billion back. He would repeal the Center for Medicare and Medicaid Innovation. He would repeal the Independent Payment Assessment Board. He would not require Medicare private plans to cover all of Medicare benefits, given flexibility to have a value-based insurance design that eliminates non-essential or wasteful services. He would replace the current what's called DSH, disproportionate share, hospital programs to care for the uninsured under Medicare and Medicaid with a new single uniform compensated care fund based on charity care only. So these are the provisions. We don't have to wait until something is introduced. To me, there ought to be a policy brief on each and every one of these that explains exactly how they would work. So, not surprisingly, since I think about this from an analytic point of view, that's not the only way to think about it, but I feel like we can make a difference. We can all think, what is my expertise? What is my passion? What are my skills? Who can I join forces with, whether that's a network, relationships, access to people in a position to affect change. But we're not powerless to deal with these proposals and can mount an effective response. Thank you.
Okay, I'm going to jump into the questions from our students, our faculty, and our staff. Congressman Waxman, if repeal is soon, but replace is delayed, what happens?
Well, if repeal is soon, well, let me back up and say, it's hard, even when you have one-party control, to do some of these things elaborated like that. We had, when President Obama came into office, a majority in both the House and the Senate, and even to the point where we got 60 votes in the Senate. And President Obama and Democratic leaders hoped for a bipartisan working relationship to develop a program that was based on a lot of Republican ideas. Competition between insurance plans where consumers would make a choice that would drive prices to a more reasonable level, improve quality. But President himself said that, President Obama said, that he would have in some ways preferred a single-payer system. But there was no way in the world he could get that passed. There were some people who were talking about a Wyden bill that would have changed all the tax system for all the health insurance in the country. And the president said, no, we can't go and change everything at once. Let's do what we can in a more modest way, which is to cover the people who don't have insurance through their jobs, don't have insurance through Medicare, don't have insurance through Medicaid, and want to buy a policy, an individual policy, and can't for two reasons. One, they can't afford it, so we said we ought to have a sliding scale help for those who need it. And secondly, because private individual insurance would discriminate. They put lifetime caps, they would charge women more for their policies, and they would charge people with pre-existing conditions so much that they couldn't afford it. So he said, that's what we want to address, that market. And his proposal has been demonized as if the whole healthcare system of the country has been taken over by the government. So that's what he tried to do and what he did against the odds, and people criticized him. Why didn't we do a single payer? Why didn't we do this? Why didn't we do that? And the answer was always, we could only do what we could do and get passed, and we were forced to do it on a partisan basis. Now it's the reverse. Republicans have their dream world. And Congressman Tom Price lives in a dream world, as does Speaker Ryan, into what they think the policy ought to be. And they passed bills pursuing these fantasies where they could pass it through the House on a partisan vote, but it doesn't become law. Now, if they want to pass a law and exercise their muscle to do it, they will own the consequences. Decisions are not made without some economists look at the economic consequences, politicians look at the political consequences. I do not believe they'll touch Medicare, although Price, Congressman Price and the Speaker very much want to change Medicare. But the only statement we have from Trump in the campaign is, I'm not going to touch Social Security or Medicare. Now, do we hold them to it? Well, we'll see. But Medicare and Social Security, if you go after them, as President George W. Bush tried to do and said when he was elected he had a mandate to do that, although it was never part of the campaign, there was a huge reaction against it. So they don't have complete carte blanche to do whatever they want. There will be hearings to decide whether to confirm the presidential nominees. And Senator Schumer said they're going to grill Congressman Tom Price very carefully about the ideas he spelled out and bring out what the impact would be. And then not only will they own the proposal, which I don't think, if it were enacted, would be welcomed by the American people, they have a constituency that they played to. And a lot of those constituents are going to get hurt the most. Low-income people and people who are sick do not go on the Democratic side exclusively. There are Democrats and Republicans, but a lot of those people have voted because they wanted a change, and they voted for Trump. So he's going right at his base. And then let's realize that there's something else. There's not a united front among Republicans, because Trump does not believe that he's delegating the authority to govern to Speaker Ryan. He even said some impolite things about Speaker Ryan. So they're going to have to sort through what they want to do. The president can't just delegate this to be done by others. He's rewarding Price, and he's rewarding the fellow who's now going to take over from Alabama, the Justice Department. Well, those are scary rewards, and he's showing his loyalty, but people are going to watch what they do. And if they try to repeal the civil rights laws and the Voting Rights Acts and things like that, there's going to be attention paid to these things. So there's going to have to be, I think, an evaluation of how far they want to go. If they get a lot of these things through, and the question, which I don't want to ignore, was if they repeal the ACA right away and say in 2 years it has to be replaced, that might happen, because they all say, oh, we want to repeal it. They also say we want to replace it, but they've never really given us a clear replacement. They'll be working on that replacement. That replacement is not going to be in a just in a reconciliation bill, even though they have another one giving them an opportunity to use a majority vote to pass something. It's going to require a lot more airing and thought and process and evaluation. So I think there are the analysis and facts and arguments are not wasted, even on people that we think may not care about the same things we care about. They care about some things that are going to be very much affected by the decisions they make on these policies. And one is historical legacy. The other is the re-elections of the members of the House and the Senate. If they're going to do a Medicaid block grant, which Republican governors are going to be faced with a difficult re-election as a result of it? Do you give them a little slack? Well, I remember Republican administrations being very partisan in how they gave waivers and did things. I remember Democrats doing that. But then you get other governors saying, well, why should that governor get a better deal? Why should a governor who expanded Medicaid under the ACA get a higher formula under a Medicaid block grant than a governor who stayed true to the Republican policies of not doing anything to help Obamacare? So I think that we need to keep pressing the issue and let them fight a little bit. Let them air these differences of opinion as we air our differences of opinion. And they may well repeal the law with a period of time to replace it 2 years out, let's say, maybe 3 years out. I think the insurance market will fall apart on the ACA before a year, and then people are going to be saying, what's been taken away from us? And what is the replacement? And it's not going to be so easy to agree on the replacement. So we've got our work set out for us, but we should not be fatalistic and think it's all lost. There have been times when it looked terrible, and what looks terrible often gives us an opportunity to advance goals that we care about. And I remember reconciliation bills when Reagan was president, where they wanted to look for some money, so they wanted to cut back on some Medicare spending, and then they had to pay us more by expanding the Medicaid program. And if they reduced Medicaid too much, is what they did the first year when Reagan was president, the consequences of a Medicaid program that turned its back on so many poor people brought a counter reaction. And then people started talking about, well, we need Medicaid even more than ever before. So we're not in a static position. There are a lot of dynamics, and we've got to try to influence those dynamics. And if they repeal the Affordable Care Act, they kept their promise, but it might be like the dog that runs after a truck and catches it, and then says, what do I do now?
Bill, there is already a lot of private insurance company involvement in the Medicare and the Medicaid programs. If the new administration goes further, this is a question from our audience, if the new administration goes further, is that all bad?
Goes further
in terms of more privatization of those public programs?
Well, I actually would suggest Karen answer that because she knows the history and the evidence about what happens if you, if you block grant Medicaid, if you create a per capita cap in Medicaid, if you say to Medicare beneficiaries, here's a small health savings account, go get your own insurance. I don't know why we think they're gonna see low-priced insurance policies unless they have huge deductibles, don't cover very much. People can get minimal coverage. But it's that dynamic that we've got to make clear now. I mean, the message, at least that Washington's taken, is that the country wants to see change. They want to see the Congress take awareness of what their problems are. Well, let's demonstrate what the problems are with these policy changes that the Republicans are recommending.
Yeah, I would just chime in and say it's up to us to really explain the differences. So one simple fact is the administrative overhead in Medicare and Medicaid is 2 to 3%. In private insurance, the Medigap policies, the Medicare Advantage policies, you're talking about 20%. In the individual market, before the Affordable Care Act set rules about what's called the medical loss ratio, it was 40%, 50%, 60% of the premium was going for something other than medical care, going for profits and administrative expense. So people get very confused about the Medicare premium support. Right now, beneficiaries have a choice of private Medicare Advantage plans, and about a third beneficiaries have elected to take those plans. So what's the difference between letting all Medicare beneficiaries buy private insurance? So first of all, those Medicare Advantage plans are regulated. So Medicare sets how much they will pay those plans, and they have to live with them. Under the premium support, the government pays not the average of what medical expenses are, but what the second cheapest private plan charges in that market. So you have to pay extra. Then they index it at something that doesn't increase over time with healthcare costs. So it's a big difference. Medicare Advantage plans can use Medicare's physician fee schedule to pay physicians, Medicare's hospital DRG payment system to pay hospitals. So they benefit from Medicare's limits on provider payment. And this is something Congressman Price has tried to say, let physicians charge what they want to charge. Why should the government be involved in setting these fees? So once you not only privatize, you take away the safeguards that are now in the Medicare Advantage plans. You're dealing with a very different kind of private plan.
It's another question from our audience. I'm going to throw it out to whoever on the panel wants to take it. Is there a reason to believe, so the Affordable Care Act included both insurance expansions, but also delivery system reforms. So the question is there a reason to believe that delivery system reform initiatives, accountable care organizations and the like, and payment around that will continue given that there's some bipartisan support for those initiatives?
I would take a first crack at that and say, what's going to happen to CMMI, Center for Medicare and Medicaid Innovation? How does Congressman Price view innovations in the way we're paying for care, whether value-based purchasing has a future? I think people in CMS and people at CMMI are very, very concerned that the flexibility that the law provided, the resources that exist to experiment and to try to find better ways to pay for outcomes, that all of that I think is at risk. And if you come to something like CMMI from an ideological standpoint and say, well, I want to privatize our healthcare system, you're just putting blinders on. And CMMI has had some successes and some other things maybe that haven't worked out as well. I don't know how Karen and others you all feel about CMMI, but the opportunity that it represents to try to find better ways to improve outcome, improve service delivery is critical to going forward. And I think what I expect will happen is that we'll see CMMI pretty much shut down.
I want to disagree with that, if I might. Before the election, I was contacted by a coalition of healthcare providers, doctors, and private hospitals, and the pharmaceutical industry. And they wanted to push an agenda, assuming Hillary Clinton was going to be president, that they said would put guardrails on CMMI and IPAB, which is a system that was written into the Affordable Care Act if increases in healthcare costs went too high. And there would be automatic reductions based on a proposal this commission or the secretary would put forward, and the Congress then had to come up with something that's comparable in its savings. And they were scared to death of this. Now I don't think that coalition is so frightened because they think that they have their friends in power. And Republicans are going to want to look at alternative delivery systems that will spend less money because they're going to give it less money. Mm-hmm. They're going to give the healthcare system less money. So I think there's going to be a split of a point of view on CMMI particularly as a way to look for innovative alternatives to fee-for-service. Now, I think Congressman Price grew up in healthcare in a fee-for-service world where providing the services was the determination of the doctor. No one should question it. And if they provided a service, they're entitled to be reimbursed at the highest possible amount because their services are valuable. We can't afford that kind of system. And we've tried other alternatives. And CMMI gives us other alternatives as we look at trying to move the whole healthcare system from quantity to quality. That was one of the premises of the Affordable Care Act. I don't think they're going to be able to repeal that. And they're going to want to use it, and they'll have a big debate and fight about it. But I think a lot of the innovations in prevention and immunizations and women's health care in the Affordable Care Act, emphasizing prevention and having services for prevention, there's going to be a strong constituency arguing for those things to continue. Of course, they can take out the funds. One of the things they use is the prevention money in the ACA to fund a lot of things that they want to do. I think partly the 21st Century Cures Act has some of that money as well. So they want the money, but they want good policies, especially if it fits in with their agenda. And once they start thinking these things over, that's where I hope the analysis done by people in this room and that follow policy will have an impact.
Very briefly, and I think this is going to have to be our last question, and picking up on your last point, one of the questions from our audience is, why should we have faith that facts matter when it didn't seem like they did during the election? Brief response, please.
Do I get the first response?
Go for it. Yeah.
They looked at a different set of facts. They looked at it, a lot of people that voted for Trump had a different reality. They looked at a reality where they lost their jobs in the old factories that used to be the mainstay of the Rust Belt. They looked at the fact that they were suffering, their communities were changing. Global trade they saw as harmful, and they saw Democrats as not interested in them. They were more interested in minorities and LGBT people, and they didn't hear any Democrat talking about the things that they cared about, and Trump made an appeal to them. So from their worldview, it was in some ways a rational decision to say, they didn't like Trump all that much, many of them, but they said, let's try something else. And they have turned against elites, which are often, well, definitely all the people in this room, who look at facts, who can make arguments on consequences, et cetera, et cetera. They looked and rejected that because they haven't seen any benefit to them. Now, a lot of these people are going to learn the hard way that as things, as bad as they are, can get worse when we can't have fair global, well, we can't have trade policies that allow us to get the benefit of lower prices. And we have people whose economy depends on exports, not just imports, or imports, not just exports, and that the things that they thought they were going to get out of all of it, they're going to come off worse if they lose their Medicare, which every Tea Party person I've ever heard or talked to says is that they deserve it. It's those things that those other people get that are not deserved, like Medicaid and other programs. And they haven't thought it through. They don't know what's really at stake until a lot of them see that they are going to face the consequences. So I think that that will all be factored in. And facts do matter, because when you have insurance and you lose it, that's a fact that's hard to ignore.
Clearly, we're in a very uncertain period, but here at Johns Hopkins, at this extraordinary institution of learning and scholarship, we take very seriously the notion that knowledge is power. For our closing comments, and in that spirit, I want to invite up to the podium Ellen McKenzie, who is the chair of the Department of Health Policy and Management.
Thanks, Colleen. First, I want to thank our panelists. That was fantastic. I think we could go another couple of hours at least, but unfortunately, a lot of us have to get to class and do other things. But as Colleen mentioned, this is Congressman Waxman's last official event as our Centennial Scholar. And I just wanted to take this opportunity to thank him so much for spending the last year and a half with us, sharing your wisdom, your good wit, and some good stories from your time on the Hill, and we really benefited from your being here with us. I think we can all take solace in the fact that Congressman Waxman continues to be an incredibly important force in Washington, and that's obviously going to be critical over the next few years. And I want to say that anything we can do as a community of public health scholars and practitioners to help make sure that sound, rational, supported policy is maintained or moves further, we're here with you, and we very much hope we can continue our collaboration with you. But thank you so much. And I think it's fitting to end this important session with something that Congressman wrote a couple of days after the election. And I think it embodies his approach to life and to politics. He said, "Let's keep our perspective. There are always ups and downs in politics, and nothing is ever easy. Change is a constant, and the unexpected is a given. What counts is our ability to adapt to new realities and stay ahead of the curve while fighting both strategically and fiercely for the causes, the values, and the people we represent. If we follow these principles together, we will get through the next 4 years and emerge even stronger for the battles ahead." And I think it's very wise counsel that we should take very seriously. Again, Congressman, thank you so much for your time with us and for all you have done and all you continue to do to improve the public's health. Thank you so much.
Thank you.